Welcome to another episode of Ask Me Anything, where I take your questions and I find the answers from our experts. And we have our medical correspondent, Dr. Tracy Weisberg, with us today from New England Cancer Specialists up in Maine. Tracy, hi.
Hi, Joan. How are you?
I'm terrific. Let's see. Today we're going to talk about just some of the ABCs, I think, of breast cancer. Let's start with a really basic one. What does my pathology report mean?
Okay. So the pathology report is packed with information about your cancer diagnosis. And many centers now provide, they call it a synoptic report. It goes line by line and it addresses multiple different aspects about the tumor. So at the beginning of the report, it's going to tell you what your cancer is called. Is it invasive ductal cancer, or is it invasive lobular cancer, or is it ductal carcinoma in situ? You know, the name of the cancer is going to be there. And then usually one of the next items that they tell you is the size of it. You know, how big was the tumor? They measure it, and then they're going to tell you the grade of the tumor. The grade of the tumor is not the stage of the tumor.
The stage of the tumor is the size, right?
The stage is a combination of size and lymph node involvement. The grade is an assessment that the pathologist makes with their eyes. As to what the nuclei of the cells look like, what the tubules in the cells look like, what the ducts look like, and they put that together and they say it's a grade. And a grade 1 tumor is a more slowly growing cancer, and a grade 3 tumor is a more rapidly growing cancer. And then on your path report, if you've had your lumpectomy or a mastectomy, it's going to talk about the margins. You know, is the tumor out? Is all of the tumor out and none of it touching to where the surgeon's blade was? So what we strive for are clear margins. And so the surgical team is very interested in this path report, but they're intensely interested to know that they got the tumor out and that they didn't leave anything behind. Another line is going to be about whether there was any skin involvement, whether there is any nipple involvement. Another line is whether the lymphatics of the tumor, not the lymph nodes, the lymph glands in the tumor, do they have tumor cells in them? This is called angiolymphatic invasion, and this is considered a high-risk marker for potentially having the lymph nodes under your arm involved. And then the path report is going to tell you whether you have any kind of precancer surrounding the invasive cancer. And that precancer might be ductal carcinoma in situ, but there's also another kind of precancerous lesion. It really isn't cancer. It's called lobular carcinoma in situ. And lobular carcinoma in situ isn't really cancer. What it is it's a high-risk marker for having a higher risk of cancer. And if you have lobular carcinoma in situ in one breast, there's a possibility you have it in the other breast. And so it's just a marker of like, hey, open your eyes, let's like keep an eye on the other side too, because we've got this lobular carcinoma in situ stuff going on. Then you would have a line item of the biomarkers. So in breast cancer, the biomarkers are, is the estrogen receptor present? Is the progesterone receptor present? And is a gene called HER2 amplified? And on what we strive for now in path reports is actually stating to what degree the estrogen receptor is present. Is it present in a small amount, like 10%? Or is it present in robustly across the tumor, 100%? Because maybe the way the estrogen blocking medicines work is somewhat contingent on the amount of the receptor. And with the HER2 biomarker, they're going to classify it as 0, 1, 2, or 3. And if your HER2 is 0, you don't got HER2. But if it's 3, you have HER2 amplified. And if you're in between, the pathologist will ask to have an additional test done to establish if HER2 is present. And then some path labs put on other molecular tests looking for how rapidly the cells are growing, called a proliferation index. And in women who have triple negative breast cancer, some pathology labs do some special stains that mark whether the tumor is of this more aggressive subtype called basaloid subtype. And then on a separate section, that if any lymph nodes were removed, they're going to talk about the lymph nodes in much the same way, and the lymph node count, and the number of lymph nodes involved is involved in prognosis and how we select certain treatments. And then on the back part of the pathology report is just a lot. It goes on, it looks long, but there's a lot of different measurements, descriptions of how much tissue came out. They'll give you the number of centimeters, and for some treatment plans that's important. Did a lot of tissue come out? Did not enough tissue come out? So that report is packed with information, and I always give my patients a copy of it. Not that they're gonna understand every single word, but at least have it so they can refer to it. And it's one of the most critical pieces of information in a cancer diagnosis, is to make sure you have a handle on that pathology report.
And boy, I remember going to my breast cancer surgeon for the very first time and having that report pushed across to me. And I just want to say to everyone out there is that I didn't understand most of what was on that report at that moment, because mine was triple negative. I'd never heard of triple negative. I'd never heard of any of it. And it was kind of like somebody could have been passing something to me in Greek or Japanese, and I just didn't understand it. But then, this is what happens to everyone as they go through having cancer and being treated, is that you learn more about it. You become more at ease, because the unknown, of course, is always so incredibly scary. But you just took all the unknown out of it, and we thank you for that.